These two leading documents produced in the last couple years are remarkable in their homogeneity. When you look directly about thinking about management, whether it be medical therapy, interventions, size thresholds in genetic therapy, and the concept of the aortic team, these are highlights. And also, I love this, the aorta as an organ. Part of the organism that's self-contained, has a specific vital function. In St. Louis, we call the aorta the tube of life. There you go. Okay, so lots of opportunities when we think about care management. These are some of the topics, broad topics that I was going to discuss with you today. And some have been covered, so we'll go over those briefly. But I'm going to highlight some of the things that I think are very much important to say again. First, we need to recognize people who are at risk for aortic dissection. That's the tip of the iceberg. So they know it, we know it, they can advocate for themselves and get right to the front of the queue when they have a symptom that could be consistent with an aortic dissection. That's life-saving. In HTAD, so heritable conditions, the importance of the size is not the only. So many other factors, specifically the variant, and so many other things that inform the variant's behavior. And then we have to make a diagnosis of an aortic dissection, whether you're the first person or the third person to see the person, taking a history, the importance of getting to what really happened, especially when it's not quite clear. Eric has emphasized the importance of getting to somebody who can help you with the lowest risk and the best possibility of outcomes. And then so many times this morning, we've learned about the opportunities in treatment, whether urgent surgery, urgent endovascular, or urgent medical therapy. And then what I'll talk about at the end is really the rest of the story, the long history after somebody makes it through dissection, and the importance of genetic testing. I'll set this up for Diana. Family screening, importance of medical therapy long-term, recognizing the mental health concerns that our patients all experience after an aortic dissection, and providing what I like to call realistic optimism, because that's what it is. We have to be optimistic about the long life that many of these people are going to, and we expect these people to experience after a dissection. So this is where we are, and of course we don't want anybody to get this question wrong, so this is how we teach. And so this is a board question for cardiology boards, could be on cardiac surgical boards, could be on general medicine boards. A 58-year-old female with poorly controlled hypertension comes to the emergency room with chest pain. She had the sudden onset of a sharp, severe pain radiating to the upper back and had left leg numbness. Her father died at 52, and a brother experienced a dissection at 55. She's anxious appearing, has a marked difference in blood pressures, has a murmur of aortic regurgitation, and has an absent left femoral pulse, and the EKG is normal. So of course, we want the trainee to get this answer right. So that's what we teach. But that's not really how it all works out. This is an actual case with the same diagnosis. A 58-year-old male mechanic who never goes to the emergency room, has hypertension and reflux, but he comes to the emergency room because he is working under a car and experiences back pain. And his mother died at 52 of a presumed heart attack. He also is anxious appearing, but his blood pressure, although elevated, is equal. And when somebody pushes on the back where he said it hurts, he said that's painful. So that's what happened. And his physical exam didn't give any other clues. His EKG showed no changes, and his labs and chest x-ray were unremarkable. So he was given morphine, which improved but didn't resolve the pain, and sent home with instructions with pain medicine, muscle relaxants, to call your primary for a follow-up. And he continued to have back pain and now chest pain over a few days, and after a syncopal event died. And this is how we got to see the family, because the postmortem demonstrated a type A dissection. And so this is the challenge. When it's easy, of course, we want to recognize it, but the majority of people with dissections may not have all the clues that should highlight how this lethal disease, when unrecognized, can still present in a more generic fashion. And in the emergency room, it's a challenge. This is an interesting study looking at 9.5 million emergency room visits, and there were 782 aortic dissections. That's 1 in 12,000 visits. And of course, just like in the IRAD, the average age was 66 and 38% female, so same demographics. And of these 9.5 million, there were 760,000 or 8% atraumatic chest pain diagnoses. So that's a lot. So that's 1 dissection per 1,000 chest pain patients. That's the challenge of an emergency room doctor. So that physician, seeing 3,000 to 4,000 patients a year, would diagnose a dissection every 3 to 4 years. And when I lecture, give information to our trainees about aortic dissection, I always ask, how many times have you been the one to talk to somebody with a dissection and made the diagnosis? And there's 1 or 2 people raising his or her hands because they're getting them 2 or 3 times down the road. So taking the history, getting that information, hearing about it, thinking aorta in patients that come to you, again, is very, very important. This is a very informative piece of information. What do we learn from patients that aren't diagnosed initially in the emergency room that experience an aortic dissection on their presentation? So here's 12 studies looking at 1,600 patients. I actually think this is pretty good. Misdiagnosis only 34%, so getting 2/3 of them in the emergency room. Not too bad. Presenting symptoms similar, more back pain perhaps. Pre-existing hypertension, only 55%, emphasizing that not everybody has hypertension with dissection. Very important to think that they can be that way. Kind of disheartening was that 4% had Marfan syndrome. Automatically should take us to the top if you have that in your history and present with a syndrome. And what factors led to misdiagnosis is when it mimicked all the other conditions that aortic catastrophes can mimic. So that can be a difficult challenge. Or when the chest x-ray did not show an aortic abnormality suggestion. But when they examined what helped make a diagnosis, because again, this is the key, we want to make a diagnosis, was asking more questions. Tell me more about your symptom. And emergency rooms, just like on the medical wards, are now shift work often, so people come on and they leave. And so retaking a history when a diagnosis isn't initially made. So these are the things that we have a big advantage on care management, to try to make the diagnosis, take a few more minutes, get a good history, what really happened, and increasing use of imaging. So we want to educate people on the front lines about what conditions serve as high risk for aortic dissection. Do they have a heritable condition? Do they have a bicuspid valve? Do they have a family history of aortic disease? Really important processes. Have you used cocaine or methamphetamine? Very important. And then take another minute. Besides just listening to the heart with your stethoscope, look at the patient differently. I love it when a trainee in aortic disease working with me goes in to see a patient, because now our second-year fellows all rotate with me for 3 weeks, seeing patients with aortic disease. So they'll see a dozen or so patients with, Marfan or Loeys-Dietz or something like that, and that they've never seen before. And they'll come out of the room and say, I didn't see it, because they went in the room thinking that this is what it should look like. And these patients are known to have the condition, yet even though that's the case, the trainees aren't recognizing it. But at the end of 3 weeks, they get it. And that's what it takes when you see something that's not that common, uncommonly in your practice. So we try to train about these things, but probably most importantly that we can all do as a care management strategy is have trainees come into the rooms with us, see these patients, get a use of what they look like, how to recognize how different they all may be than what we write about in the book chapters that we do. So I think this is a good quote. Let's have them see things wisely. Okay, and so we write about this. Do patients have a condition that's at high risk for dissection? A quarter or so do. Again, I think most patients with dissection fall into a pain category that highlights the attention for this. Tell me more about it. Describe exactly what happened. And take the history yourself when they get to the floor and it wasn't diagnosed, and then you may make the diagnosis. And of course, if they have a high-risk feature like this have-to, you can think about aortic dissection. So thinking dissection with more points than not, you're going to do a CTA early. When you don't have a diagnosis, do a D-dimer. Lots of patients are diagnosed after a D-dimer is performed to look for pulmonary embolism. That's fine. They get a diagnosis. So never worry about a normal testing. We've heard already this morning how important making this diagnosis is early. And in the very acute phase, 0.5% per hour, where surgical therapy makes a big, big difference. What do we learn from that important paper from the IRAD, from Kevin Harris and others, that rapid diagnosis, of course, and treatment saves lives. What do we know about the delays? Because there's always a delay. But this is pretty good, really. Time from presentation to diagnosis, 2.5 hours. In many emergency rooms, if you get seen by 2.5 hours, that's the miracle. So, having a patient that we know this could be their condition, say, I'm worried about an aortic dissection. So telling a patient that you follow at risk for dissection, what is a dissection, what it could feel like, and how to advocate for yourself will get you to the front of the line every time. And as I tell my patients, I'm always happy when the CT is normal. That's the easiest diagnosis to treat. So that's fine. And again, diagnosis to surgery of 3.5 hours, that's pretty fast. 6 hours from arrival to surgery in an IRAD center, of which 70% of the time it's a transfer, is still pretty good. But there are mechanisms. Eric talked about this morning. I'm just going to highlight a couple of the points that he brought up for us. These regional care models are really important. So establishing relationships. In my experience, one of the biggest delays is actually finding emergency room to hospital transfer where there's a bed. There's no bed available. So you find out that 3 or 4 or 5 hospitals were called to try to come up with a mechanism. So to get the person to the right place at a right time. Eric talked about this. I'm just going to bring up one point. So this was a study looking again at what we can learn from volumes of hospitals to predict maybe a better outcome. And what I found most interesting is you say, well, okay, let's get to a high volume center. What does that mean? It means doing 7 aortic cases a year. That's called high volume, and only 10% in US Medicare populations do 7 proximal, which includes the arch, cases in a year. That's called high. 90% do less. And then when you look at where patients end up, as Eric said, half the patients get sent from a no volume center or in a low volume and stay there, or get transferred to a low volume center. So we have a lot of opportunity perhaps by regionalizing care, and it can save lives. So again, that's the rubric that was written into the guidelines, that it's perfectly appropriate when possible and appropriate to get the person from a low risk or no risk to a high risk center. Now, one thing that Eric said is important is where are these centers? So the darkest green are high volume centers, and more cases done in high volume centers. And as you can see, as you get out here to the Midwest and the West and the high plains, there's a lot more centers that don't do a lot of aortic surgery. And as Eric said, he showed a nice map of the New England, way of the world, which is 50 miles is a long way. When you live in the rest of us in the middle of this country or the West, 50 miles is called a neighbor, okay? That's a neighbor, okay? So we don't really think about it like that. We get people transferred from hours away because that's where they have to go, and that's the right answer. So this just shows, again, these big green circles are places like Michigan and Cleveland and all up and down the East Coast where there's lots of opportunity. What I think is interesting is look at all the red dots next to a green dot. I mean, they should definitely be transferred. You don't have a choice when you're out here in the big sky country. You have to go somewhere else because that's where you should go. And again, having the knowledge that 0.5% per hour, that's a game changer when we talk about liability and things. You need to be transferred. So I think this is a big advantage in these papers and this sort of study. We talk about this all the time in the aortic center. To get good at it, you have to see a lot of cases. Now, obviously, surgeons don't have to do one every day, unless you're at Cleveland Clinic, then it's required. But you have to do a lot of these, and that's what we know. The more you do, the better you get, and the better the outcomes. And you learn from your mistakes and what you do better. This is a great study from Chad Hughes' group at Duke showing when they changed the way they approached aortic dissection, you can drop the mortality markedly. And if you take away a program that just says everybody does whatever comes in the middle of the night to one that does the most cases and they're set up per surgeon, you can see outcomes are just a lot better. This is another paper from Michigan from Alex Brescia, who's now at WashU, just showing again what's been talked about again. If you do a dozen cases or so ascending or 10 or more descending, and this is at a center, you can see outcomes are better than very low volume centers. So again, we have the information, we have the data, so this is very important. In Europe, it's the same. Beautiful paper by Martin, Tim, and others here looking at should we have them stay or should we be sent to a center of excellence? And there's challenges when you have to send somebody away to somewhere else. The hospital has to have operating rooms, ICUs, nursing care, anesthesia, blood bank, all these things available for those patients that are going to come. And if you're the surgeon, if you're Himanshu, you can be on call several days in a row and do all these cases, but not everybody's the same. So you have to have enough personnel to manage this availability and to say we're going to accept all these patients. So that made it into the guidelines, again, in both centers to get patients transferred. And there are care pathways that one can use to do that, of course, where single sort of lines of action to get the patients in, get imaging done to make sure that the appropriate patients have the appropriate disease on transfer, get them on medicines, and when appropriate, have a team ready because you already know the diagnosis. Eric went through this earlier, so I'm not going to highlight these two things from the Harris paper. This is from Arturo Evangelista and the IRAD group showing the improvement of mortality over time in surgical and endovascular with dissection. Again, we talked about many of these things this morning. These are all care pathway advantages with type A, type B, that are going to change care over the next years. I'm going to end with really what I think is probably one of the most important things that we can do for our patients and families after the aortic dissection and care management, and that's having a meeting. And this meeting, whether it be in the hospital or in the clinic first time up, I think it's the most important time that you're going to have with a patient and a family. They come with a lot of anxiety and worry and questions. This is not a 10-minute, 5-minute post-op check. You really need to set aside the time for either yourself or somebody else on the care team to have this meeting, to have all the discussion. Show them a picture of the aortic dissection. It doesn't ever surprise me when I see a patient after a type A repair that went beautifully for me to say, you have a dissection the rest of the way down that we're going to monitor, and they just look at me like, you are kidding me. I thought I was fixed. I didn't really know that I still had this to deal with. What? And that's not rare. So we have to make sure we educate people in a way that they understand exactly what they are and explain what all these next steps are and then provide realistic optimism. And this paper from Dr. Bassani, beautiful paper from the IRAD, and this is what I'd like to tell patients. You didn't succumb to it. You made it. You made it to the hospital, you made it to the emergency room, you made it to the operating suite, you made it out of the hospital, now you're here with me. 90% of you are going to be the same at 3 years. That is so uplifting, and it really gives tremendous opportunities to make life-changing things because we expect you to be alive. We expect you to live a long life with this aortic dissection, so how are we going to give you good quality of life? So that's when you've set them up now and you can talk about all these lifestyle changes, behavioral changes, importance of looking at your relatives, doing the genetic testing, how often to image. You have to come back. Your blood pressure is under your control. I will help you manage it. Stop smoking, live your life, be active, and we'll take care of your mental health. All these sort of things. If you can treat with a beta blocker, you're going to do better. If your blood pressure is tightly controlled, you're going to do better. Simple things that help patients live their life. So this is part of it. So finally, again, care of the aortic organ is an aortic team. Beautiful paper by Scott McClure and other Canadian experts looking at care models. Who's involved? Whoever you have that have interest and expertise. It can be some of these people, it can be all these people, it can be in person, it can be virtual. Really just depends on what your local expertise is. But you can see so many members who are involved in this team. The challenges is there aren't very many aortopathy specialists. There aren't very many medical geneticists, as Eric highlighted earlier. Family screening, lack of importance, awareness of that, genetic testing, and the insurance coverages. I think our group here has a way to emphasize national policy that says people should be able to see doctors and specialists and geneticists, et cetera, who can help them even if you don't have their insurance. You have to have meetings to discuss strategies with all the stakeholders and especially trainees to see how is it done, coordination of care, et cetera. That's the aortic team advantage. And this is just one figure from the Canadian paper looking at all the different ways that a team can help get people into the clinic, appropriate management, surveillance, family planning, treatment, and when acute events occur, whether timed, planned, or emergent, experience, and then back into the follow-up. So in a quick 15-minute survey, you can see that there's a lot of advantages in care management with this team approach. lots of opportunities, education, awareness, treatment, and I think the way as I think Tor said earlier, or maybe Kim said earlier, the advantage to a team is immeasurable. So thank you very much.